My pleasure.
Awesome. Fantastic. All right. Well, I'm going to get us started. I know there are still people flowing in. We were going to go Facebook Live today also, but we decided at the last minute, if anybody misses this, they can catch the video at firstprinciplesofmovement.com. There'll be a link to our YouTube. I want to thank our students, Geronimo from Florida and Aaron from Minnesota. If it were not for them, I'm not doing this. I'm not that savvy and know how to do this stuff. But a little bit more than just 3 weeks ago on a Saturday night, they suggested that I do this. And we've really been at capacity in each and every one of these webinars. I know there are people that have tried to get in that couldn't. We're really pleased to have this opportunity to welcome everybody to this forum. And starting with the second webinar, I've been joined by Ryan Chow, physical therapist from New York City. Ryan, you want to say hi to everybody?
Hi, everybody. I'm glad to be back here with you guys. Hopefully I can help answer some questions or help facilitate all of this, and very excited to have all our special guests. So thank you.
So last time from Finland, Perttu joined us and asked some very insightful questions. Clearly, Perttu was the smartest person in the room, and his questions had a lot packed into them. And I thought, I just sort of felt that that was something that was very inspiring and challenging at the same time. So I reached out to two people who I respect enormously, whose work has influenced a lot of my thoughts over the last couple of years. Peter Stilwell from Canada and Matthew Lowe from England. I want to welcome you both, and thanks for joining us today.
Happy to be here. Thanks so much.
Thanks, Craig.
Each of them has authored some rather momentous papers that were really dropped on me at a moment when I was in galley stages practically for the third edition of Rehabilitation of the Spine. Some of you may have noticed that the third edition carries a different title than the second. And the first, we changed the subtitle from a practitioner's manual to a person-centered approach or a patient-centered approach. And this was something that was a long time coming. Many conversations with our next guest this Thursday at 4 p.m. Pacific Standard Time, Lorimer Mosley. And I have had a lot of conversations post-Lancet about whether the high-value approach as espoused by Lancet, which many of us see as consistent with the evidence-based guidelines that have been promulgated since the late 1980s, and yet have failed to move the needle in terms of practitioner implementation. In other words, we've had dissemination of innumerable guidelines all over the globe on high quality musculoskeletal care, yet practitioner behavior just doesn't seem to change. We continue to see in excess of passive care, corrective exercise approaches. We see that people are saying things that we hear here on this webinar, such as how hard it is to motivate people to comply with exercise programs, how to convince people that are fearful that activity is the road to recovery and that not every hurt equals harm, how to dispel some of the myths from labeling and from language about pathology and pain, and to address those really deep yearnings that people have to want to know why they have pain. And of course, the easiest thing to attribute as a cause of pain is something you see, something on an image, something on a scan. But we all know we want to treat the person, not the scan. And so these are issues that have been coming up. Perttu brought some of those to the fore. And so today is our chance to really expand the discussion and the dialogue by bringing in two people, again, who are world authorities who've thought through these problems at a very deep level, but also can express it in a very simple way. Because as Einstein said, we want to make it as simple as possible, but no simpler. So our goal is to make the hard easy. A quote from Pavel Tsatsouline, that's true strength. And strength in our mindset is very important to be able to tee things up for people in a simple way. It's not about making it complicated. It's already complicated. It's about having a GPS to simplify all of this complexity. So I'm going to start off, and then I'm going to weave Matt and Peter in, if that's okay with you guys, with you, Matt and Peter. I'll call on you throughout. Does that sound good?
Sounds good.
And Aaron and Geronimo will be feeding questions to Ryan, and we're not going to necessarily even wait till the end, Aaron. We'll go from time to time. So this is some contact information. People can feel free to email me after the webinar, any questions they have that we didn't get to. And of course, you can follow me on different places, and you'll see that I often tag Peter and Matt on Twitter. So you can link up with them as well. First of all, we've done our little Texas COVID preparation. We should all wash our hands as if we just ate a bunch of hot jalapenos, and now we're about to take out our contact lenses. But we're going to deal today with how to put on our face mask.
You will fight with us jointly as we work to defeat this pandemic. So our efforts has been great. None of us are.
So there we go. One of our leaders, one of our great leaders, the governor of Florida, needs a little tutorial. So let's talk a little bit about this shared problem that we all experience in terms of different messages that are out there, a lot of different silos, people having different opinions, citing different evidence, urban myths, if you will, about the musculoskeletal health problem. And it's a big problem. Maybe no bigger than trying to manage the big oil rigs in the North Sea, but certainly we have some big issues. It's increasingly clear that simply expecting individual clinicians to adhere more closely to guidelines is going to close the evidence practice gap. So bridging that gap between science and practice is the goal. And Croft recently wrote a paper with Nadine Foster, published just in April of 2020, that addressed one of these major issues about knowledge translation. We see that effective high-value care for people with back pain, as an example, and high-value care is care that they defined as something that has more probability of benefit than of harm, will only be achieved through large-scale top-down changes across health and social systems. In other words, what they called system strengthening. And I would contend that COVID-19 is a pretty large-scale top-down phenomena, and maybe for the first time since we began to disseminate guidelines in the 1980s, we have something that from a social standpoint, from a policy standpoint, is actually influencing the behavior of practitioners. One of the big things that we hear, for instance, from chiropractors in South Africa, in Wales, and elsewhere who are attending our webinars, is that it's very hard to address patient expectations. Patients are expecting us to use our hands. They're expecting a fix-it approach. They want passive care. And of course, physical therapists and chiropractors want to give people what they want. They also want to give people what they need. But some people feel like you should slip the pill in with the applesauce. And other people, like trained, for instance, by somebody like Robin McKenzie, feel the acute care situation is where you have an opportunity to dispel expectations, to violate expectations, if you will. And if you can get a person to feel better without you using your hands or your modalities, then you can change what they expect, and they can begin to attribute to something that is within their own power to deliver to themselves, namely self-care, self-management. So here we have, for the first time, something more powerful than all the guidelines in the world. We have an upstream barrier or constraint that is requiring us to guide by the side. According to Croft and Foster, the results paint a bleak picture. Only a minority of patients apparently receive the simple positive messages to pursue self-care, exercise, while inappropriate use of analgesia and imaging persists. So this is the sort of the tragedy of musculoskeletal pain. The care doctors give to patients with back pain is dominated by guideline discordant interventions that are unnecessary, expensive, and of low value, defined by them as the harm is greater than the benefit. So I know my special guests will have a lot to offer on these topics as I've listened to them and read them. They also have a shared passion to dig in deeper and to see why knowledge translation is so poor. I've seen the statistic. It takes about 20 years to get 14% of evidence into practice. Knowledge translation is the great challenge that all of us who are teaching are trying to overcome, because we don't want to just explicate. We realize that everybody is in the same boat. And it's not that we're smarter than anybody else because we have a platform. We're all in the same boat, and everybody has different challenges. The questions really about the behavior of practitioners are not as simple as just explaining the facts and then expecting physical therapists, chiropractors, trainers, coaches, medical physicians, etc., to instantly be able to change what they do. There are a lot of constraints. We've heard from some of our guests from England that the reimbursement system and the expectations of the public is that, hey, I have 15 minutes, people expect me to do some massage or some adjustments, and to change that is not a very simple thing. I'd love to throw this to you, Matt, right at this juncture. You're in a consulting role. And of course, you've been on the ground floor of some of these guidelines and the implementation and dissemination of them, but also dealing with practitioners who have certain barriers to carrying them out. Do you want to say a few words about this sort of burning issue?
Yeah, I mean, it's a massive topic, and thank you very much for inviting me. I think perhaps some of the things that we would want to try and unpack here when it comes to knowledge translation is what's come before us, what was the embedded culture that we've come from, and if we go back, what is the antecedent is biomedicalism. Now we know that biomedicalism has had a significant impact on the welfare of humans. We've eradicated smallpox. There's a number of diseases that we've managed to treat very, very effectively. But it was embedded in a culture of treating the disease, where you treat a person, or rather you treat a patient who's lost their agency. Now, when we're looking at long-term diseases, let's say, for example, musculoskeletal or non-communicable diseases, should I really say, it's all about empowerment and agency. So if you're trying to provide or facilitate people becoming active agents in their care, this cultural shift from a biomedical patient who has lost their agency into now a situation where the person should be empowered to self-treat and call on others appropriately. That's a huge shift, just a fundamental shift. The patient as person who's lost their agency requires the x-rays to see the pneumonia, requires the blood tests to have the diagnostic identification. So if you look at it from a patient's perspective in society, that system has worked. It works. So why shouldn't it, from their perspective, work in this other world? And it's that shift fundamentally from our history and the culture that something has seen that has worked into something that is a little bit more vague, is a little bit more difficult. It's propagated by the idea of non-specific, which then us as practitioners, and I'm going to hold a wide lens there, will try to fill the gap, and that inference gap, i.e., we start making up our own diagnoses to fill in these gaps. Yeah. You talk about it quite a lot, Craig. The upslip pelvis, the rotated, the cross, and so on. And that's not out of any sense of wanting to do harm. It's done in the best interest, but it has unforeseen consequences. So the knowledge translation gap is trying to recognize the history, see what the current context is, and translate that into reality of the current situation in the current context. So for me, knowledge translation has to draw from that. And it's, I think if patients are going to come with us, the other thing I'm very cognizant of is the tendency for, we have to, as practitioners, have to move away from biomedicalism ourselves. And that includes allowing patients their agency as well. It's a very challenging context to be able to say to somebody, actually, well, I shouldn't have to tell you what to do. I would like to give you information so that you can make an informed decision. And often that decision is self-management. But the idea of the difficult patient is overcome once you walk beside them, and they come with you on this.
I love that. This idea of empowerment and walking beside the person seems to me like at LA Sports and Spine, we have a mission statement to give people tangible hope and an achievable plan. And the way we do it is by giving them a positive experience with movement. I feel that most of the people I see are seeing me because of a couple of different reasons. One, they have severe pain. Or two, they have a more moderate pain, but it just is persisting. And in either of those cases, they're not able to figure it out on their own. So most people have musculoskeletal pain. We realize they never see anybody. It's mild enough that they don't seek professional health care for it. But when it's either very severe or it's extremely persistent, they come and see us. So it's always been very obvious to me that if I can give people a positive experience with movement, then they have less fear, and then they become more empowered, to your point, Matt. But I think that the danger is that the placebo is so strong that sometimes when we use our hands, people think of us, and we've referred to it in past webinars as like a superhero. They see us as Batman. And that relationship has led to kind of a dark side where it's bit us in the butt in the long run because people don't develop, I think I understand what you're saying, that agency. They are not resilient now in the future for handling the inevitable flares. So they keep going back to the fix-it, which is a short-term solution. In the medical paradigm, that leads to interventionism. It leads to stronger medication, even NSAIDs taken for arthritis. It has a side effect of increasing cardiovascular disease risk up to 40%. And it also has the unforeseen consequence of taking away an opportunity, which Professor McGill calls the gift of injury, which can help people with what you mentioned, all the NCDs. And even now with COVID, we know that if you are sedentary and overweight, that's pro-inflammatory. And so there are so many ways of looking at this. Peter, would you care to sort of jump in here on this issue of maybe people's expectations and how clinicians, chiro or physio, get roped in to this sort of superhero role instead of guiding by the side?
Yeah, thanks again for inviting me to be here. Happy to join in. You introduced us as experts, Matt. Yeah, for sure. I wouldn't put myself in that category. I watched the third webinar that you guys did. I watched the recording last night, and I was like, damn, like just hitting on all my biases and expressing a lot of these kind of complex issues in ways much better than I could have. So I really appreciate what you guys are doing. But I think what it comes down to, and what Matt really tied in, is the cultural shift that's needed. So you mentioned the low back pain, the Lancet series, right? So they talk about trying to move this cultural shift forward, and they mention in the one paper that it's not just about shifting the beliefs of the clinicians, but it's also the patients, which is incredibly difficult. And I think it goes back to early on, and we can tie in that you talked about COVID, right? And this concept of universal precautions, right? So I borrow this from Catherine Harmon, my PhD supervisor. So if we treat all acute patients like they're going to be chronic at some point in the future, if we express that pain is multifactorial and there's things that we can do in the short term to modulate it, but there's also these things that we can do in the long term. And a lot of those long-term things are more geared towards empowerment, as you guys have already mentioned, geared towards self-management, doing things for themselves in the long run. And that goes from that, I like how you put it, Craig, the Batman versus kind of the butler perspective. And I've definitely early on in practice tried to be the Batman, right? And try to go in, find the problem, try to fix it. Short term, you get the high fives coming out of the clinic, which I think reinforces that behavior. And obviously there's financial incentives as well. But really, if we're looking at what's guideline-based care, what's the best thing that we should be doing for patients, it should be really keeping our eye on the things long-term and expressing that from the get-go with every patient and doing everything we can to get them empowered, get them self-managing. I think it's hard though, because then you start to not get the high fives in the clinic. You start to push people a bit further. So in your last webinar, you talked about finding people's kind of limits, right? And then building from there. You don't always make friends sometimes doing that. And I think that goes back to building those skills of how to build a relationship, how to start to nudge these things and move a person towards more kind of self-management behavior.
Wow, that pretty much hits the nail on the head. You don't get those high fives, maybe, but I want to show something I got from one of our faculty in London, Rachel Locke, on how telehealth can be a surprise to the practitioners. She sent me a note. Telehealth is moving forward. Each day, more patients are signing up. I like how personal it is, getting patients to exercise in their living rooms, reassuring, coaching, and having a chat. Rachel Locke, London. So, maybe it's like science. Science it always sort of violates our expectations. We get more questions. We don't get more answers. We get more questions, and we discover things that are unexpected. And this is an ultimate experiment right now. This is an experiment on the planet like none other that probably any of us have ever witnessed. We're seeing that now we have a constraint, and we're forced to be the butler, to be Alfred, and to guide by the side. And through the medium of the screen and people being in the comfort of their own home, it's turning out that there are other variables here at play that are leading to this whole interaction being a lot more positive than we would have perhaps ever guessed or imagined if we just thought about it logically. So the telehealth experiment is here, and I think it has an opportunity to accelerate knowledge translation. Facilitating telehealth has unanticipated benefits of actually promoting high-value musculoskeletal care, because now we can't do passive care. And people don't have the access to going in for injections, let's say. You can't occupy nurses and hospital services right now for elective things such as musculoskeletal pain. I want to show a video here of one of my telehealth sessions from actually just yesterday.
Absolutely. But before I came to see you, Craig, it's been like a year's saga of many other practitioners, acupuncture and physical therapy and spine surgeons and pain management doctors. So I've sufficiently got my mind muddled and overwhelmed. So it's helpful to talk to you just to get refocused and to cut through a lot of the baloney that's upstairs from bad prior experiences.
I think you're sharing a common experience. I think the the pain field is the original field of charlatanism, the snake oil, and it's overwhelming with Dr. Google, and people have your experience. It's not yours alone. I think it's not something you're imagining. It's so real. Like your pain is real, but that doesn't mean the pain is all like in a joint or a muscle. There's the whole process. It's how we react to the pain and then what we do about it. And waiting for somebody to put their elbow in your side to like massage it out is sort of fool's gold. It's like a cough drop. And you know, we're working on your foundation and you're getting strong. And so then that begs the question, well, I'm stronger than those people who are out of shape, so why aren't I better yet? It's complicated.
Yeah.
And I'm the first to admit, I don't know the timelines, but I definitely know a lot of the landmarks. So we know we want you to run. We know we want you to play volleyball. You've expressed sensitivity in things that involve twisting. So we want to work on getting your body to be able to resist twisting. And we found certain things like the left hip is really stiff turning in and it's sensitive turning out. And the left side lunge or lateral lunge is really a lot different than the right one.
Yeah.
And then we find things that help you. And then now we're learning, as far as running, that running isn't necessarily going to be like a snap of the fingers. So let's add in some short hill sprints, and let's add in single leg hop and hold, and let's keep doing all the things that you already have discovered through effort and through grit and mindfulness that warm up that left hip. That's your program. All that stuff that helps the left hip it has a positive cascade. Sound good?
Sounds great.
What would you say if you were talking to your wife is the biggest pivot to avoid getting yourself down because progress isn't fast enough?
Did you say that what's the biggest pitfall to avoid?
Yeah, what's the biggest pitfall for Nate to avoid if you're talking to your wife with respect to dragging yourself down because progress isn't fast enough? I mean, albeit, how much progress have you made?
A lot. I mean, I think we talked about it. When I came 5 weeks ago, I was almost at the maximum pain tolerance that I could handle. Incredibly uncomfortable, thinking surgery or more cortisone shots, and now pain's down to a 1-2 or maybe a flare to a 3, which is uncomfortable, but it's incredibly manageable. So I've come a really long way, you know, when you take a step back and look at it. And I think that's the key to your question, Craig, is I've got to just take a step back and look at all I've accomplished. And I think that's the key, is just focusing on the progress and recognizing that the progress has shown results, and then to have confidence that it's going to continue to show results, and this is all going to resolve itself. And don't get too wrapped up on, am I running tomorrow or in 2 weeks or 2 months, because it's going to come.
How does that make you feel to say that?
It feels good. It feels really
good. Yeah, I love that.
good.
So let's focus on what you're feeling. And the mechanics are all going to take care of themselves, because we're not going to stop focusing on the mechanics. We're going to always focus on the mechanics. We're going to spend 90% of our time focusing on how you move, and we're going to keep learning to make you move better. But how you're feeling is those are the lenses through which you experience all of this. And whatever you feel is real. Like your pain is real. Your pain is totally real. And the way that the experience of the chronic pain makes you feel, that's also totally real. I mean, your wife knows that. She knows how you're feeling better than anybody.
All too well.
All too well. So let's not submerge any of the doubts and worries and concerns. They're part of the package.
Okay.
this is a mind-body thing. I studied philosophy. I never would have thought I'd get into a career where I was actually going to use it. And you're in the finance world. There's a lot of behavioral economics, isn't there?
A lot. More than people think.
Especially now, people freak out and the market tanks.
Absolutely.
About expectations, isn't it?
Expectations and emotion.
All right, so we'll call it at that. That was a good session.
Perfect. Yeah, I appreciate everything, Craig. Thank you very much.
Okay. So these sort of conversations that a lot of you are now starting to have on telehealth, like Rachel said, are in many ways even more focused and more personal than we were able to have in an office where we're maybe getting interrupted. There are other patients around, other clinicians. I'm curious, Ryan, if you want to chime in here about how you've made the transition as it's been enforced on us in New York City, more than in most places, away from your beautiful gym in Union Square to meeting with people online through telehealth.
Yeah, the telehealth challenge in front of us is a lot, in a lot of ways, been a blessing because of all the things you're saying. Is at first it was slow because people's expectations and their values don't lie in education or empowerment and things like that. People expect, like you guys have been saying, to be fixed, so they didn't see the need to come for any help. But as more people see that this is going to go on for a while, they start to change. They're starting to look for something. So then they come and do telehealth, and they realize that it's a lot more effective than they thought it would be, because the telehealth set up the constraints based around it, shown people that what I've always tried to explain to the people that I work with is that the exercise is just kind of a vehicle for education. And it when you have context through interview, and you get a thorough interview, since we can't do as many hands-on tests, people are okay with me doing a long interview with them. People are okay with me giving them time to talk and listen and to understand their context. They see how relieving it is, and also how helpful it is. And now they understand why they're doing their exercises. So we start to break all these behaviors, and we shift away from maybe impairments and work on more behaviors. And it's okay, because that's what they have to work on. We can't follow up as often. We can't do a lot of hands-on stuff. So I think it was slow at first, but I think it's catching on. I think more people are receptive to it, and I think it's something that will stay. And for the future, I've done some surveys, and people actually said, "Hey, we'd actually like to continue with some of this virtual stuff." So I think it's been awesome so far.
I know my patients appreciate not having to commute.
Yeah, definitely saves time, right?
I want to throw it to Peter and Matt. This comment that Ryan just finished with about it's more about behaviors and less about impairments. And you saw me also ask my patient how he felt about his emotions. These are things that aren't so available to the conversation in the clinic. There's other people around. In somebody's home, I've got a pipeline right into their home now. So I'm curious, I know this is a new phenomenon, but how do you two feel about what Ryan just said about we seem to have more access to people's behaviors, and it's less about the specific impairments now?
Go ahead, Peter.
Yeah, I think you hit on a lot of the benefits already. So it's setting up the situation where the expectations are automatically changed already. So you're not able to actually lay your hands on them. You're not able to do some sort of manual therapy or some sort of so-called fix, right? And automatically that shifts patients' expectations to, yeah, we're going to be having a conversation. I'm going to be guided. I'm going to be having to do movements in my own living room or bedroom. So it completely shifts the focus. And I think we can start to harness that, right? And as you already mentioned, Ryan, you already touched on this, and Craig, you touched on this. People get surprised they get surprised and they say, wow, I didn't realize I could actually start to feel better without my QL release or without this manipulation. And they start to realize pain can be changed in different ways. We can start to harness exercise. We can start to harness educational ways to shift the way a person views their body and the way they interact with their environment. So I think there's so many opportunities for this, and really just to reinforce that pain is multidimensional, multifactorial, and there's multiple ways that we can approach it and ultimately set the person up towards self-management. So it'll be interesting to see how, once the face-to-face interactions start coming back, how patients' expectations will start to shift. And like I just do research now, and I just see, I used to see patients, and I used to see that change though, right? You'd see the people that looked for the fix. They went around to the different clinicians, and they finally just said, hey, I got to do something different. I got to start doing something for myself. And they have that moment where they start to change their expectations and the way that they want to approach it. So I wonder if we're going to see more of that in the future. I hope so. What are your thoughts, Matt?
Yeah, I echo what you're saying. The key thing, I think, if we use that excerpt as a that beautifully identified how Craig found, or he zoned in on that person from the respect that I can't remember. Was he an economist? Is that right, Craig?
He's in finance. He's in finance.
Yeah. So you'd picked up the way that he was thinking, the way that he valued mechanics, and then you said to him, "Well, look, this is 90%. Yeah, 90% of this mechanics." But at the same time, you're talking about feelings, and feelings. Yeah. So you kind of, you recognized where his value was. You placed the importance of where his value was in the way in which you imparted your care, but then you added the extra, which is actually way more than the mechanics. We're going to let you think this is all about mechanics, but actually it's about how you identify with yourself, with your family, how the whole picture really is intertwined. But you did that at such a kind of personal level that he kind of didn't think that you were trying to psychoanalyze him. You weren't trying to pigeonhole him in this kind of psychological box. Yeah. Mm-hmm. You identified what he valued, and you massaged through your interaction the best possible outcome, which he identified with, not just at a personal level, not just in a physical level, but an emotional level. And that is something in which, you know, that level of resonation is going to facilitate a positive change.
Thank you. I think some of that is inspired, believe it or not, by a non-clinician, Mark Verstegen, who founded Exos, our #1 performance training center, where he's laid out 4 pillars: movement, mindset, fuel, and recovery. And he said in a short videotape he recorded a couple of years ago, he said, at Exos, we're always going to be about movement. Movement's always going to be #1. But then his whole talk was about mindset. And how everything starts up here. And mindset is the cornerstone of performance, because that's where confidence is. And without confidence, there's no performance. If you have anxiety, if you have negative thoughts, then of course it disables all the movement potential. So let's take a look at some of the architecture here as we move forward. Obviously, people come in with expectations, and one of them, and we're going to talk about a couple of them, is they want to know the cause of their pain. I want to ask you guys, how do you balance that expectation with the multifactorial nature of pain? And I'll give you a little more here to chew on. People's expectations, they want to know what the cause is. They want to know what we think they're going to need to do to get better, and obviously what they may have to do for themselves. People have certain expectations as far as what we're going to do on that actual visit itself. And then, of course, there's the fact that most of our patients have seen other providers. And you mentioned this, Peter. People go from provider to provider looking for the right fit. a nice study here showed that most individuals discuss persistent back pain as being like a broken machine, something immutable. And they spoke of it in a negative way, in a complicated way. And most participants indicated they learned those beliefs from their healthcare professionals. So I think that that's sort of an indictment of the iatrogenesis and the nocebos that come from us. In contrast, we can begin to pivot away from talking about things like a machine or a broken part as mechanics. And this was a big pivot for me in Rehab of the Spine from the 2nd to 3rd edition. We actually eliminated the chapter on biomechanics in the 3rd edition. Here they're saying osteoarthritis is usually considered an entity related to wear and tear, a linear process. I know both. A more apt view of osteoarthritis is of a process, dynamic and changeable, with many contributors. Howard Lux is a medical doctor I often dialogue with on Twitter. He says this very, very clearly, not mincing words. Osteoarthritis is most often not a mechanical wear and tear process. Obviously, people think that it's caused by wear and tear, and too many healthcare professionals are telling their patients to stop activities because that's the implication. If you have a wear and tear problem, then you want to stop the wear. And what really shocks me and what helps open the door with my patients is that I point out to them the studies that we have more arthritis today, yet we're more sedentary. And in scientific investigations, comparing the bones and joints of modern people today versus the x-rays of people in the 1940s, there's more arthritis today than in the 1940s, and yet we're far less active, measurably so since 1980. And if we compare modern people's joints to people's bones from the industrial period, there's more arthritis today, yet obviously we have less wear and tear than they would have had. And then if we compare people today to fossils of prehistoric people, cavemen and women, 7 million, 6 million years ago, again, we see that these highly active cave people have far less arthritis. So the whole idea that, oh, we're going to take a scan, oh, you have degeneration, oh, it's wear and tear, now you need to stop being so active. Obviously, it's not a logical thing, but it doesn't mean in the milieu that people are coming in to see us with all their thoughts and beliefs that it's that simple to get them to pivot. So Peter, I want to throw this one to you first. How do you thin slice all of that?
I wish I had a great answer for you. It's so complex, right? And I like that, viewing osteoarthritis as a multifactorial process, because that's how I view pain, as a process that always involves many different factors interacting, mixing together, ultimately to have pain emerge. So I wonder, like, it's so difficult because patients and when we look at the evidence, they don't respond well to being told what to do, or really kind of confronting their beliefs verbally. So I think this is where kind of behavioral experiments or graded exposure can come into play. So you guys already talked about that in the last the webinar that you did, number 3, about violating expectations, right? So you could violate expectations through different types of exercise maneuvers, and this is something that could even be done through telehealth, right? It can be done virtually, and people can then realize that they can do things and modulate their pain without you doing some sort of magical fix. And I think this is where you get people starting to shift their beliefs and starting to shift their narratives because they're actually experiencing it. And I think we can then reinforce that with the words that we use. So lately, I've been quite interested in the use of metaphors and the different types of metaphors that we use. So we all use them in clinical practice. Metaphors serve a bidirectional purpose. So patients often use them to explain their pain to the clinicians, but clinicians also in turn use metaphors to explain a patient's pain back to them. And so we kind of co-construct these metaphors together. And I wonder if what I've been calling lately multi-dimensional metaphors are the ones that we should be starting to move towards. So whether that's to explain pain or to explain osteoarthritis. So an example of a multi-dimensional metaphor that I think most of you have probably maybe used or heard of would be the cup analogy or the cup metaphor. So there's all these things filling up the cup. Some things make the level of water rise. Some things actually make the level of water reduce or empty the cup. But ultimately, if enough kind of things combine and the cup overflows, that's when we feel or experience pain. So it's taking something quite simple and concrete, but expressing the multidimensionality of pain, but also that overflow of emergence. So all these things combining together, and there's an overflow. And with that, I wonder if we can start to talk. I don't think it's a perfect metaphor, but then we can start to go, hey, like what factor caused the cup to overflow? And we can't just pinpoint one thing. There's all these things interacting together. And so this isn't mine. Other people use the cup analogy. And I know Butler and Mosley used like the bathtub analogy in 2003, right? And explain pain. But I still think those types of metaphors may have utility and move towards some of these things that you're talking about, right?
I love that. And actually, I know in your Barbell podcast with Catherine Harmon and yourself, she brought up the social determinants, and we have all these lifestyle factors that all are part of the milieu, if you will. And we talk in terms of NCDs, I think, Matt, about the SNAP, smoking, nutrition, alcohol, physical activity, stress, and sleep, and of course, social participation, as all being factors that may have more to do with somebody having musculoskeletal problems or even cancer or heart disease and affecting our lifespan, our biological age, than other things. There are pictures like this floating around showing that these healthy behaviors, if you can marshal them, can contribute more to your health than access to even medical care. In quite a striking fashion. And these are just the lifestyle factors. And then, of course, we get into the social determinants, which is what you and Catherine addressed, right, Peter? And social determinants are even more upstream, obviously, than and are maybe the drivers of the lifestyles. And I think that's where we're seeing the practitioner behavior now is being nudged upstream via COVID-19. And can we marshal this later to help change the relationship, the therapeutic alliance, if you will, between clinician and patient? But I know in England, I'll throw this one to you, Matt, issues about lifestyle are a little bit of a slippery slope. And in New York City, Ryan deals with a very highly motivated, affluent population. To a certain extent, I have a similar population in Los Angeles. But there's a lot of work coming out of the National Health Service in England about that maybe we shouldn't talk so much about lifestyle, because a lot of people, like we see African Americans in the United States, having a very high percentage of the COVID cases that are hospitalized. Within a 10-mile radius in Washington, D.C., poor African Americans versus affluent people in Georgetown, a very nice affluent area, completely different rates of going to the hospital and of mortality due to COVID-19. And these are, to a great extent, socially determined. They're not genetically determined. And I'm curious, Matt, your view on how, as clinicians and coaches, we should frame our attempts to influence lifestyle in the context of the big picture of the fact that a lot of these things are socially determined, and we really don't want to guilt people that are obese or who are sedentary. How do we tiptoe into this to become part of the solution for them?
Yeah, so I think I think it comes down to, I mean, this is at a personal level. It's really about respecting that person for who they are, rather than see them as a group of these contributing factors that we kind of, you know, categorize in our clinical reasoning. The first and foremost mindset is that this person, you know, first and foremost is a human being, and they come with their own perspectives, their own history, their own uniqueness, and there's plenty of good reasons to present the way they are presenting, and some of it and a lot of it isn't due to choice, which is exactly where you're coming from there, Craig. So I think so genetic and the field of epigenetics is very much environmentally influenced as well. So the idea that we historically have seen genetics as being a determinant of the manifestation of disease and health is now blurred with epigenetics. So how do I tiptoe into some of those challenging conversations? So in the case of patients who are people who are overweight, the overwhelming majority of people, they don't need you to tell them that they're overweight. So that, you know, so what's the purpose in actually achieving that? I think having conversations with them where they identify what their goals are. I've never found a patient an overweight patient who hasn't actually determined that one of their goals is weight loss. If you're talking to a public, like a population level, I think you've got to have that conversation. But at the individual level, the individual knows what these issues are. They don't know necessarily how to overcome them, and you can ask tentatively questions surrounding the situations that may make the obesity a problem or make it arise. Talk me through a typical day. And as soon as you start to recognize what their kind of lifestyle pattern is, then you can ask further questions about that lifestyle pattern. So these are patterns of behavior which I try to identify, as opposed to the consequences of the behavior. So I'm not going to say, oh yeah, you know, the consequence of the behavior is obesity. That they already know that. Don't need to go into that. I need to understand the lifestyle patterns and the behaviors, and it's those attractors of a complex system that we can sometimes tap into. Yeah. So asking these questions of, you know, talk me through a typical day. And then you start to realize that this person's getting up at 6, getting the breakfast ready for the kids. By the time they get out, they haven't actually had time to feed themselves. So they've grabbed themselves a quick bar on the way out. As they get out, they get into work. The work, as soon as they sat down, the boss is on them. Yeah. So you build up this very rich narrative, and it's that sense-making process between yourself and the person that has the greatest value. So it's that, I call it intersubjectivity. Lots of people call it different things, the third space or whatever. But it's really that attempt at us both making sense of each other. So, you know, as it's that fusion of horizons. Yeah. So you know, one person's experience meets me, and I meet them.
Wow. That's incredible. The third space, I like that. I think talking about a difficult topic, maybe not a very popular topic in amongst physical therapy and chiropractic, like things that hamstring us in even influencing lifestyle, because this is sort of where a lot of the more fix-it type of passive care oriented providers derive their fuel, their justification for why they're doing what they're doing. They say, well, it's hard to influence behavior. Compliance is low, adherence is bad, people aren't motivated, so I'm just going to get them out of pain. And this is actually providing the highest level of service that I can offer. So in a way, they're almost more evidence-based when you look at it from this big top-down view of how hard it is to influence lifestyles because of all the social determinants that are upstream. Peter, as I mentioned, you and Catherine Harmon addressed this on the Barbell podcast. Do you want to speak to this issue of social determinants?
Yeah, I think you already touched on so many awesome points. And I guess part of what it seems like Matt was tapping into is motivational interviewing, right? And I'm sure there's many listeners here today that are much more knowledgeable about motivational interviewing than I am. And I know many of you are. And it isn't as like there are starting points where you can start to tap into some of these skills and use them in everyday clinical practice, or use them as a trainer. One resource that for those that are looking to learn a bit more that I would recommend is the BMJ Learning Motivational Interviewing module. So it's really simple. If you just Google BMJ Learning module, it's a 1 hour type of training session. There's different types of kind of interactive boxes that you can click and read through different kind of scenarios, but there's also videos. So you can see it actually in real time and look at some of those examples of what Matt's talking about. So how to ask kind of evocative questions, how to listen appropriately, and how to actually, you can set the agenda to a certain extent. So you can actually start to focus the conversation, and you're not fully telling the person what to do, but you're giving them options. And so you're shaping the conversation. And because as Matt already said, like, if we're talking about weight loss, if we're talking about obesity, patients have already heard it. So we got to take a bit of a different angle. So that's one resource that I think is quite helpful. So the BMJ Learning Motivational Interviewing, even simple things like the 5 A's of obesity through the Obesity Network. That's another resource. It just talks about ways that we can actually communicate with patients to talk about things like weight, talk about things like healthy eating, exercise. And I think we can make things quite simple, and simple things can be effective. So even like goal setting, prompting a patient to set goals. I think sometimes we overlook that as something that's being important. Sometimes we want to impose our own goals on patients instead of provoking them to identify their own goals. So those are some of my thoughts to add in.
That's great. Let me ask you another tricky one here that we all face. Getting back to the idea about metaphors, and in a couple weeks we'll have the great coach Nick Winkleman with us, who's got a new book on communication, and he's done a very deep dive, his PhD, in dealing with analogies and metaphors and language, and how it motivates and enhances performance or hampers it. But we have all these metaphors, like if it hurts, don't do it. Again, let pain be your guide. Is again coming from the medical angle. After they've pathologized the pain, then they tell you to let pain be your guide, which in my mind is only going to increase the rest. But if it hurts, don't do it. And then the counterpoint is that if you're doing exercise, well, that must be no pain, no gain. And that wouldn't make any sense. So how would you advise us, and I'll start with you, Peter, to address the nuance of the evidence-based guidelines, which is that not every hurt equals harm. So if we take a step back and look at the evidence-based best practices guidelines, they tell us that there are certain ideas. One of the ideas that's biomedical is that you have pathology, and that hurt equals harm, and we should think in a different way. We don't want to think that the tissue is necessarily damaged, and going alongside not every hurt equals harm is the idea that activity is not necessarily harmful. We even screen for this in our yellow flag screens. So we'll ask people, do you believe that activity should stop if it is painful? Do you believe activity is dangerous? And most people who are chronic pain patients, they answer in the affirmative very strongly to those yellow flags questions. So even before I've seen a person, I have them fill out these surveillance forms, and we ask a couple of these yellow flags questions from a rebro or start back. and we unmask these cognitive ideas that people have about the relationship of activity to pain and the relationship of hurt and harm. So I'm just curious to hear each of your thoughts on these metaphors.
Yeah, I think you hit on a lot of the key points, right? So screening for as a starting point. So you mentioned the start back. That's one that I really liked when I was seeing patients. I mostly saw patients with low back pain, and it's only 9 items. Really simple to use. You can stratify patients into 3 different groups: so low, medium, high risk, and from there there's tethered evidence-based treatment. So if a person is very low risk, we got to be more minimalist. We don't need to provide as much support as the person that is more high risk. And I think we can start to then untangle some of those beliefs in the people that are more high or medium risk. What are their thoughts? So if it hurts, don't do it. A lot of people have been told that in the past, right? That are experiencing persistent pain. So what are their thoughts around that? What are their beliefs around that? And I think a lot of times it comes down to people thinking that injury and pain are the same thing, and that increased levels of injury automatically equal increased levels of pain. And as I know, most of the people aware listening in, and all of you guys on the panel here, is we can start to untangle that and express that, yes, we can actually experience some pain. And it's not always a bad thing. And we look at Ben Smith's pretty recent systematic review that for MSK conditions, chronic MSK conditions, going into a little bit of pain can actually have short-term benefits over not going into pain. In the long term, it kind of washes out to be about the same. But essentially what the review suggests, that we shouldn't be afraid to nudge into a bit of pain for most kind of MSK conditions. And in fact, it can be a bit more helpful. So I think we shouldn't be afraid of pain and shouldn't conflate it with injury. And tackling that with a patient, I think, is very individualized, depending on what their narrative is, depending on what their concerns are. Easier said than done, that's for sure.
Yeah, Ben Smith's work has been a real game changer for me with Chris Littlewood. Matt, do you want to echo any of that or nuance that?
Yeah, no, and I totally agree with Peter. I would also go so far to say that because the issues around pain is associated with meaning. So what does that person, when they experience pain, what does that mean to them? And I think as soon as you elicit that meaning, sometimes it isn't a problem. And sometimes when you actually explore that with them, they say, yeah, I thought it was a bit weird when that other PT or whatever said that, oh, if I feel any pain, I should stop. So it's just going that extra little bit, that extra yard, saying, when you feel that pain, what do you think's going on? Just an open question like that. And then as soon as you understand where they're coming from, then you can tailor it and then you can contextualize it and move forwards.
Ryan, I know you deal with a lot of people that are very, very, very successful, and they have strong opinions about things. How do you address this issue Matt's bringing up as far as the relationship of hurt and harm?
Yeah, it's tough because a lot of their friends are like they're the top doctors or the top orthopedists or whatever. So it's hard when they see like a young guy like me telling them something opposite. They're like, well, you're not really a top doctor, but like Matt mentioned, they kind of already have a suspicion that it doesn't make sense. Otherwise they wouldn't be there to see me in the first place. But I think maybe if it relates to structural pathology, like if we hear first what their belief is and then try to figure out, the one that I do the most often is just show people that if it was a structural thing and I didn't structurally change anything, why can something hurt 10 minutes ago but it doesn't hurt as much now? So if they give me enough information and context about what their beliefs about pain are, I can try to start to change their mind over time. And it needs repeating because 100 different people are telling them that hurt equals harm or avoid every little pain. So I have to layer by layer start to chip away, start like over time disprove that belief while still validating all their beliefs, because they're all really smart people. I think a lot of them, they're so successful and they're so smart. I think one trick that I use is I let them try to explain it to me so that they feel like they're the ones who arrived at this. And, you know, I don't need to be the hero. I don't need to be Batman and say, hey, you know, that's what I told you 3 weeks ago. You're just saying it back to me in a different way. But, you know, I let them, I try to get them to do that. And that way they feel like, you know, I'm guiding them towards it. And then they start to believe it more, because ultimately it's about the epiphany that I see you try to get. When I watched you with Nate just now, I just saw you validate like 50 different things that he said, thought, or felt in 100 different ways. And I was like, wow, it really takes so much of that. And I think that's one thing I really learned watching you work with people. And that's something I try to emulate.
Another one I'm curious, Matt and Peter, how you approach is, I'm always very, very stressed when people want to know, when am I going to get better? I'll tell them, like, you know, what you have is not like a fracture. So I don't have an exact timeline. And I've learned from Dan Papp, a great sprint coach at Altus in Arizona, that we should focus more on landmarks than on timelines. But I'm curious to hear your thoughts on how you navigate the uncertainty of timelines with musculoskeletal pain, and balance giving hope. And I know there was a paper a long time ago by Dan Churkin about satisfaction, patient satisfaction, and he said that there are people that need a rosier outlook because they're a little down, and the only way to get them going is to give them a more cheerful outlook. But there's other people who will bite you in the butt because when they're not achieving those landmarks at a certain time, then they become more frustrated. So I don't know that there's a perfect answer, but I'm just curious to hear from you guys about your thoughts on this one. Jump in.
So I guess when it comes to managing prognosis, I usually use the idea of us going on a journey. And although I get snapshots of the journey, I never walk the journey with them in its entirety. That we're both on the journey together. And so if the presenting complaint is something that is associated with a tissue healing with a very, very clear pathoanatomical source, then I will give a rough guideline on when we feel that those tissues are likely to heal and the things that may impair them. So, for example, if they have diabetes, you know, or peripheral vascular disease or whatever, some of the kind of comorbidities that may slow that healing process down. Or, for example, if it's neuropathic pain, that adds another layer of uncertainty with regards to prognosis. So with your clinical reasoning, you can kind of come to some kind of judgment, but say to them, look, this is a real kind of ballpark idea here. Whatever the outcome is, I'm here with you. We're going to do this together, and we're going to try and optimize your outcome whichever way it goes. So I think it's recognizing that uncertainty in the first place, working with the information that you do have, but also making it individualized to that person, so that person recognizes that you know your beans, you know what you're talking about, and that you also can offer that support with them throughout that journey. And there are going to be a number of different hiccups on the way. So there are some nice analogies out there with regards to the bumpy road, or the Toblerone type recovery. So Louis Gifford describes it. So there are a number of different kind of sources that you can draw prognostic indicators or prognostic outcome from.
I know one of the things that we use at Reload in New York City at Dr. Chow's place, and I use at LA Sports and Spine, is this is one of the images that I'll give to a vast majority of my patients to try to help them to see that before symptoms are going to consistently improve, we want to see that function is is the goal or the target first. So if we just focus on the symptoms, I analogize it to chasing our tail. We want to get to the source. And of course, the source is sort of the holy grail, but like we don't always know the source. There's not just one source. So it's a conundrum, but we like them to have something tangible. So we focus on function first. And I have a saying at LA Sports and Spine, function better to feel better. So this picture goes with it. And it also shows the red line is the pain line. It shows that the pain's going to go up and down for a bit. And then you can expect to see progress so long as we get we lift your floor. We showed a Clint Eastwood from Dirty Harry video. You probably saw it if you watched the last webinar, Peter or Matt. A man's got to know his limitations. And so we're always trying to find the floor. We're always trying to help people to understand that one of the key factors in why they have musculoskeletal pain is they don't have adequate capacity. They don't have what they need in order to achieve their goals. And so now we want to bridge the gap from what they have to what they need. And we try to tie this together. It's logical. I don't know that it always resonates, but Peter, do you have any thoughts on this topic of the expectation regarding prognosis?
Yeah, I love what you both already hit on, and I guess one thing that was exciting for me to hear is having those early conversations that there are going to be flare-ups, there are going to be setbacks, and I think we should be having that discussion before it actually happens, so the person isn't calling in, having an emergency, having kind of that fear associated with it, feeling like they undid all their progress or did something wrong. So having that early conversation that flare-ups and setbacks are perfectly normal. That said, we always got to be talking about red flags too. Yeah, having vigilance around the rare situations where there is pathology and something does go seriously wrong. But most patients we're not going to be seeing those types of things. So having those early conversations. I love the slide here. The bumps in the road, those are expected and normal. Can set expectations right from the start.
So this is an article from Journal of Orthopedic and Sports Physical Therapy last year. I'll just read the top part that I put in the blue box. Clinicians often assume that interventions directly influence recovery of patients with musculoskeletal problems. In reality, other factors may influence recovery more than the direct treatment provided. The most powerful factor may be upstream effects such as economic stability, education, health and healthcare, neighborhoods, built environments, social and community context, commonly determined social determinants of health. So somehow, I don't know that we need to comment on this, but I just wanted to tie back together prognosis, bumps in the road, if you will, with these other non-mechanical factors. And, you know, everybody wants us to fix them. It just seems behaviorally, the strength of our therapeutic alliance is really challenged when it comes to these issues about how much can we do, what are they expecting us to do, whether it's with exercise or manual therapy, and how long lasting these things are going to be in the face of all these other influences that are going on. So I don't know if that's really so much as a question as I just wanted to throw that out there and share that. It struck me as a very clear statement of the context, the environment, if you will. And these environmental factors are as important as the diagnosis, the tissue-specific factors, or the biomechanical, the bio. They're just as important as the psychological. Does that make sense to you? I know, Peter, you speak about this a hell of a lot.
Yeah, it makes sense to me. And I guess we had a paper 2017 talking about this in the context of low back pain and exercise. So there's a lot of times we think that, exercise has these mechanical effects, but there's these other contextual factors at play too, right? So mastery over a situation, a sense of control, building in self-efficacy, all those things can have an impact as well. And I think what you're getting at too with the social determinants of health is sometimes there's things that are modifiable and sometimes there's things that aren't. So things like genetics, certain types of kind of physical environments, sometimes it's very difficult to shift those types of things. So it seems that we should really be looking at the broader picture and then also looking at what's modifiable and what's not, and where's the low hanging fruit that we can kind of jump on to get the greatest kind of rewards or the best outcomes.
I love that. This is a quote that I like to share with my patients about the process, and it speaks to what you were saying before, Matt, about the journey. And we really don't know when the symptoms will go down, but we know what the process entails. We know that we need to get people to feel more self-efficacy by hook or by crook. We need to somehow empower them, which you mentioned. Both of you mentioned earlier. Krishnamurti, the Indian philosopher, said, just because the window is open, there's no guarantee the breeze will blow in. However, if the window remains shut, there's no possibility the breeze will blow in. So, for me, this is a way of taking the pressure off. They may not understand it or buy it, but I throw it out there. And then the process, of course, is teaching them how to self-manage. We do a lot of focusing on positive attributes, resilience attributes, so we don't get trapped in the loop of just giving more cough drops and doing reactive things. How well it works is variable. It's an individual thing, and we certainly can't be the right fit for everybody, which you talked about, Peter, how people will doctor shop. I want to talk a little bit more. I just sort of planted the seed there about something we could spend the whole 2 hours on, about this issue of the biopsychosocial model, Peter, and that construct. So I want to sort of hit that a little bit. Why the pain science versus biomechanics question actually misses the big picture. So this has been turned into a huge thing thanks to the internet, I think. And it always surprised me because I've known about pain science and biomechanics issues since the mid-1980s. And there's always been these views about psychology, views about how sad and tragic it is when a medical doctor or orthopedist looking just for the evidence on a scan can't find the correlation and then tells the person, well, we didn't find anything, you're fine. Very dismissive. And there's a paper on how that feels to the patient, this dismissiveness. And that's when they don't find something, which is rare since there's so many false positives. Just as bad is when they find something and then they attribute to that thing, which you can't change short of a deep intervention, such as surgery. And we know it's more often than not a false positive. And I'm always thinking, I want to do something where we can get the most impact. I want to get the most from the least. I want to have the least downside risk. And to me, that's the high value care that was spoken about in the article from Croft and Nadine Foster. High value care has greatest benefit, highest benefit, lowest risk. So all that's kind of packed in here. And I know from your incredible paper, Peter, you talked about the biopsychosocial model as being very admirable from Engel because biomedical thinking was too pathologizing, and that we need to look at the environment and the context that the person is in. And I was really blown away. It really helped me, as I said in the outset, to pivot from a practitioner's manual for rehab of the spine to a person-centered approach. And I never understood the social at all. So Gordon Waddell talked about the onion model and all this, and they always used the term, Gordon brought it into musculoskeletal medicine way back when in his Volvo award-winning paper in '86. But I just dismissed the social. For me, it was the bio and the psycho. And now I'm wanting to learn more about social, whether it's the environment we create to gamify exercise with constraints, like Paul McCambridge is doing in Wales, or Perttu is doing in Finland, or Nick Winkleman in Ireland, or whether it's talking from a policy or a population view like Matt was referring to, where it's the lived space, the lived environment, green spaces, parks, more no car zones and things like that, if you will. It's really the old view of kinesiology, which I realize now, the last couple of years, I'm starting to have respect for fields outside of PT and chiro, like occupational therapy and kinesiology, who always had function at the forefront, in a way that I think physical therapists who became very movement based, and chiros, very much about the paraphysiological movement, have sort of lost this environmental construct. So for me, I want to thank you, Peter, first of all. I think that you helped me to see that it's not an either or question, and that we don't have to dichotomize it if we focus on the person and the environment. So I just wanted to say that and have this opportunity with you here. But I want to quote you here now too, and I'm going to probably be sharing some of your quotes, which is a little awkward, but the boundaries between biological, psychological, and social are artificial, and the model is often applied in a fragmented manner. So Peter, can you just talk about that for a sec?
Yeah, thanks for your kind words about the paper. And yeah, we're building on the hard work of many others, especially philosophers going back a century, right? So we do highlight like how the biopsychosocial model is really helpful. It's a great kind of starting point, and however, we do identify there are some theoretical limitations, and there's also some issues that we tend to see come up when people start applying it in clinical practice. And one way that I've started to think more about it, and the way I've started to connect these things, is the concept of affordances, and how affordances are built into our perception. So the paper was largely on perception, the perception of pain. So what are affordances? So affordances are possibilities for action based on a person's abilities and the environmental features. So it's a possibility action, and it's a relation between those two. So if we look at it, the affordances aren't a property of just the person, and they're not just a property of the environment. They're that connection between the two. So they're almost like invisible in a sense. You can't point to it in one specific location. So if we start to think about perception in this way, we start to collapse those dichotomies and those trichotomies, and realize that perception involves all these factors. So it involves a full person interacting with their environment to bring forth perception. So although there, I guess some people will say, well, can we have the same perception? I think we got to think about, okay, each individual is their kind of own entity in a sense, and they have a specific direction or angle, for example. And so if I'm looking at a glass here from a certain angle with a certain body with certain genetics, and you're looking at it from a different angle and a different body and a different past history, we're going to be looking at the same thing, but we're going to have different perceptions of it. So that's how we started to kind of collapse these dichotomies and trichotomies, and started to look at kind of the whole picture. So I'm not sure if that makes sense, or if that's still too a bit philosophical.
No, that's spectacular. And I don't know if y'all are familiar with this recent paper, but it sort of shows all of the radar diagram view of all the different variables. It's so complex. And I think it's helpful for us to have windows to think about things, such as what you're saying. If we look at the relationships between things, then we begin to dissolve those dichotomizations and trichotomizations even. So there's so many factors. All of these different lifestyles. The sleep is one of the ones we have to screen. Are people lonely or depressed? Are they socially engaged in life? Are they lacking self-efficacy to engage? Are they physically active? accepted the belief that hurt equals harm or that activity is dangerous? What is their recovery expectation? All those things are all who make up the people that we try to take care of. Another quote that I'm going to read of yours, many back pain clinicians currently debating where the pendulum should swing towards the biological lumbar disc pathology as the driver of back pain. There's a lot of people that want to find the specific cause of mechanical back pain, if you will. If 1% or less have red flags and 8 or 10 or 12% have nerve root compression, the other 88, 90% have what we call non-specific back pain. Well, we can't say that to patients. Does that mean that we should flip the script and we should give them what they want, which is us saying, oh, we found the specific cause? That's like the holy grail, isn't it? We found the specific cause. Or is it better, like Matt, you were talking about, we'll tell people that there are all these different variables. And like both of you are saying from Mosley and Gifford or Butler, there are all these things in the bathtub, and then the bathtub spills over. So, Greg Lehman talks about that. So I think we're all very, very, very up to date on how there are people out there that are saying that there is a specific cause. And if you don't tell people the specific cause, shame on you. We're going to strip you of your license. You're not qualified. You're not a professional. If you're a training professional or you're a healthcare professional, you should be able to analyze the person and identify the specific cause. And this will give them hope. So like, you're the good guy. This is like presented as an empathetic thing to do that. But is it not, in fact, disingenuous to do that when, in fact, it isn't that hard to use the bathtub or the cup analogy and to a certain extent explain things without oversimplifying, which I think the mechanical can be an oversimplification, which, like giving passive care, can bite you in the butt down the road, can it? I'll throw that out to you, Matt, first.
Yeah, so I was really lucky to be part of a research project called Cause Health, and it was working alongside philosophers, scientists, medical professionals, physiotherapists, and so on. And we were looking at the metaphysics of causation. Before people start switching off, it really comes to the fundamental kind of questions about exactly what you're describing there, Craig. So this idea that there is a single cause, single effect, that A plus B equals C, and that can get us into a number of different problems. And in human biology, where complex open systems interrelate amongst systems, the idea of coming to that singular cause and effect model is probably just non-existent. And this is where a different metaphysics, dispositionalism, which is the tendency toward an effect. So rather than talk about necessary sufficient conditions, so often things are done after the fact in medicine. So somebody presents to you with back pain, and you give a history. I'm going to give a really simplified version, and they describe bending forwards. So the mechanics, the biomechanical study suggesting that forward bendings loaded the disc. The symptoms follow a kind of pattern that's non-radiculous. So then you start to make these ideas through deduction that it's a discogenic back pain. So then you come to these false assumptions based on very linear models, and often clinical reasoning tends to follow that. They tend to follow a very kind of A plus B plus C plus D even. One of the problems is that even with the cup analogy is that there are cases where you may have identified all the contributing factors, or you feel that you have, yet whatever intervention that you may have had within the modifiable factors is not sufficient to make the effect. Yeah, we've all seen that in practice. We've all done it. We've all identified it, and we haven't actually had the successful outcome that we had. Or equally, we have patients where we're thinking, how the hell did that even work? This patient's got better, and I'm like, there are these surprises that happen all the time. Yeah. So the idea that the causation is a linear model is just, in my mind, just doesn't make sense. So dispositional, so tendencies towards or against the manifestation of an effect. Actually, that really opens up our opportunities as and we obviously we're in a physical therapy forum here, but I think beyond physiotherapy or physical therapy, and this idea of a kind of singular line with dispositions tending towards and against, it looks kind of linear, but really the manifestation of that is non-linear. And it's coming to terms, and it comes back to your uncertainty question, Craig. We have to be humble because we will never know these answers. But it's the way in which the knowledge that we process this knowledge and how we communicate that with patients. So there's been a number of people, and you have to choose who you kind of have. But if that's your kind of perspective on things, then you can be tentative but reassuring with the direction of where we should go. And so I think understanding or having some kind of view on how we look at causation is really, really important, because it frames everything we do. It frames our clinical reasoning. It frames our prognostics. It frames our treatments. And, you know, it builds upon, actually, I mean, Peter, your work is very compatible, I think, with dispositionalism. And I think there is a way in which there is a pragmatic way in which those kind of theoretical models can really make sense for clinicians.
Wow, that's money. For our audience, that was the whole presentation today right there. And it's a scary word, dispositionalism. But this comfort with uncertainty seems to me to be where we're headed, where we want to have an agile GPS to be able to handle the fact that we don't have cookie cutters. This isn't about cookie cutters and protocols and recipes. We're not baking cakes. This is what really makes the Therapeutic Alliance sing for me, is just listening, just being with somebody, letting them tell their story. I find a lot of the systems out there, they've got, you know, like people are asking me, what's your screen, Craig? Show us your screen. I do a needs analysis. I ask a person like Peter O'Sullivan would, tell me your story. And then I find out what their concerns are and what their fears and their worries and what they think is wrong and what they're expecting from the visit. And I identify what their goals are. And when I know what their goals are, now it's becoming more apparent what I'm going to need to assess to see if they have what they need. Do they have the current capacity to do what those goals require? And then we can bridge the gap. Then we have the process. It's not a cookie cutter. Our audience is full of people that have invested a lot of money in a lot of systems. I know Dostoevsky talked about systems and the danger of trying to put these artificial frameworks. I mean, this is your work, isn't it, Peter? These artificial dichotomizations, trichotomizations. For me, when I look at things that are algorithms that don't even start from the history, don't even start from the person and their environment, their context, that to me is now starting to show me how little I knew about the social and how I was so bio and so psycho. So Professor McGill talks about how foolish it is to focus on the psycho when the person has anxiety because they haven't been treated properly. Well, Dr. Levitt said that's not abnormal illness behavior, that's normal illness behavior. So I know exactly where Professor McGill is coming from when he says that. You know, he'll even refer to the physicians who pathologize the pain by emphasizing too much the bio as, you know, those bastards. How dare they, you know, give that person that sentence of you have this pathology and there's only one solution, it's surgery. And also he'll say that, you know, that's not an excuse for us to go the other way towards saying the pain is in your head, that's a disservice, because there are things we can find. It's a spectrum, and we can find a place where we can give people hope, give them a tangible hope and an achievable plan, things that we can intervene on through the movement approach, the functional approach, which I think is what we're to a certain extent talking about. But there's layers to this that I'm hearing from both of you, Matt and Peter, about this interaction. And here's one that somebody else quoted you saying, Peter. The biomedical understanding of pain is problematic as it inaccurately endorses a linear relationship between noxious stimuli and pain and is often dualist or reductionist. So I realize that this isn't just applying to the pathoanatomy or the imaging problems, the structural pathology. This is the equal warning to us about biomechanics, isn't it? And even to a certain extent, Matthew, motor control. But Peter, I don't know if you want to talk about that first.
Yeah, I think you already hit on all the kind of key points, right? I love it. And you even tied in some Dostoevsky, so I'm loving it. I'll pass it over to Matt. Like, I think you brought up some really great points before about like the uncertainty and the variability that happens. Like, just because something A does not equal B automatically. And I wonder how the cup analogy could be used to better suit that. Like, because I've thought about that, and I'm like, can we say like people have different size cups and they fill up at different rates, and it's variable? I don't know, and I think that's the difficulty that we all run into, is because we're taking something very complex and we're trying to relay it into something a bit more tangible in a clinical visit. And I think that's what your vector model, I don't know enough about it and I want to learn more, but I think that's what it's getting to, is you can start to map these things out while still embracing uncertainty. I don't know.
Yeah, that's it in a nutshell. What you're trying to do is trying to come to terms with the relative contributions of causal relator, but at the same time, each one of those causal things, or the causal factors, may in themselves create a different causal element. So the challenge is that it's not a simple thing as just, okay, all the things that contribute on this side, all the things that kind of gate it on this side, and then we just map out the sum of the two parts. It's the interrelationships between the two, and it's so difficult to visualize that. But it's a way in which we try to kind of take a step forward to kind of map that out.
I want to grab a question from our audience here. Ryan, do you have a question for us?
Yeah, I have a couple. One is from an anonymous attendee. It says, should we screen patients for social determinants of health and how they may be contributing to their pain condition? What role should PTs and chiropractors take in these matters of public health?
Matt, you want to grab that, or doesn't matter, Peter?
So should we map it? I think talking about the patient story, we will get a bit of an idea of it. The challenge is with any questionnaire that we give, people will still provide the answer that they might think that do you know what I mean? It may not be genuine. It might be the answer that they think that you should be given to you rather than genuinely from them. So any kind of questionnaire might not give you all the answers, is what I'm saying. But the story, often they can tell you the story. The next question, so in a nutshell, yes, I think we should. But secondly, the challenge is that we've already kind of touched on it, is what do we do about that? How much can we support that person? And I guess that really comes down to us as physical therapists. Can we support that person's work situation better? Can we support them through a letter to social services? Can we, we might not be able to directly influence those factors, say, for example, financial problems or issues at home, but we can certainly vouch for them. We can be their advocate. And I certainly think that, we can. But, and I think the reason why perhaps physiotherapists may not want to go down this path is that they feel so powerless with it, because they are things that we can't necessarily facilitate as directly. But I think we can always, support people.
That last point, like, there's not much we can do. We're powerless, but to support them, all we have to do is listen to them and acknowledge it, and explain that it's a factor. And in fact, it can grease the whole process, because if in fact it's a factor and we're acknowledging it, and it's one that our manual therapy or exercise isn't going to address, that may actually make the person less likely to be frustrated with slow going and flares. we're going to intervene where we can to help them cope better. This is the positive approach rather than the negative approach. I don't know, Peter, if you want to say anything.
Yeah, I love everything that you guys just mentioned, and I guess the question was about addressing like the social determinants of health, and I think always, yeah, we should be looking at those things. So yeah, some of them we can't change, as you mentioned, Craig. Like sometimes just even knowing that can be quite helpful. But other things like education and literacy is involved there. Physical environments, social support, and coping skills are part of the social determinants of health. So knowing what type of supports are available and helping them get the supports that they need, making referrals as needed. Culture is another one. I think all these things we should be considering, not only in that first encounter in a subjective history, but ongoing, because those things can be changing or impacting a person. If we're talking about pain, definitely can have an impact. Yeah.
Mm. So one of the papers that to me was paralleled both of your work was from Daniela Vaz from Brazil, and she tied together from the international clinical, I'm going to butcher this, the ICF. It's the International Classification of Functioning, which the World Health Organization has used over the decades to identify handicap and disability and impairment and rehab strategies. She's described how historically it was a very disease-centered biomedical framework that has now become more person-centered. And in describing that, she basically arrives at the same arguments that both of you echo. And so I often encourage people to read her paper, which to me was a very clear statement about these issues we're discussing. She said intervention at the level of the disease or of symptoms, so either pathology, chasing pathology, chasing the scan, the degeneration, or just treating symptoms, which leads to like an opiate crisis, doesn't impart skills to a patient within a task-specific context. So she's really clear that things like motor control exercises that have been given to people that have had strokes or spinal cord injury or cerebral palsy, different neurological rehab instances, has turned out to be a fool's errand. And I know in the sports performance world, I know in the orthopedic rehab world, orthopedic physical therapy, there's a grand tradition of taking the neuro rehab motor control approach, which is kind of a cousin of stabilization exercises and things like that, saying that there's a right and a wrong way to do these movements and then breaking them down into parts. Vaz's point is that breaking things down into parts and then expecting the person to be able to recapitulate them later in their skills, in their context, in their environment, actually lacks robust evidence. Now, Matt, I know this is a big part of your work, and it was the subject of your Viewpoint article, which just blew my mind in JOSPT. We're going to revisit this in about probably 3 weeks or so. I think we'll go one-on-one on this issue of motor learning for skill acquisition versus motor control, the whole corrective exercise cottage industry, which is another kind of bio thing, I think. But would you just kind of give us a snapshot overview of some of the language issues when we say somebody has an unstable or faulty movement pattern, and sort of the ground that it's not as solid as a lot of people think it is, people who are adopting the motor control hypothesis?
Yeah, I could talk a long time about this, so I'll try and keep it brief. So essentially, there's a lot of unpublished work that I did surrounding the concept of motor control. So I looked into the philosophical foundations of it, and I did a concept analysis of it. So I'm going to cut to the chase. When it comes to motor control, if you look at the research literature, motor control becomes a construct by which the people who create it has meaning for them and them only. It is not something that has universal meaning. What does that mean? So it means that when you look at the physical therapy literature, motor control mainly focuses on muscle size, power, timing, stability. If you look at the neurological literature, it usually means things associated with smoothness, effectiveness, functional achievement. Whereas if you look at the pediatric literature, it's usually surrounding the context of the movement of the eyes, the position of the head of babies as they grow, and is what is developmentally appropriate. So whenever people talk about motor control means different things to different people in different contexts. So it is entirely context dependent. So then if you then start to hammer it down to back pain, then we've got to see it through the lens of the people who are looking at it. And at that time, it was very biomechanically focused. So it came from the work of Bergman, who was an anatomist who looked at the discrete elements of the skeletal anatomy, and that founded the theories and principles by which stabilization exercises came from. And in order to do that correctly, we had to box people in these categories. So this is the idea of reductionism. Yeah, so you've got back pain. We try to reduce your back pain to this particular problem. If I correct that problem, then you're going to get out of pain. So it's this idea of taking a complex system, reducing it to its smaller parts, changing those smaller parts, and hoping that's going to have a positive outcome. And so the motor control concept analysis work I did echoed what Daniela Vaz said perfectly. In the neurological literature, it goes further with Bobath, which is essentially a neurodevelopmental model where you'd have to have discrete stages. If you couldn't do a certain task properly, you would stop. You could not progress. You had to be able to turn your body or do it in a certain type of way before you even progress. There was a very linear way to progress. And then you had the functional, which is exactly where she's coming from in terms of a step up. If it's the number of repetitions. If we break down a small task into its component parts, we repeat those parts, and then we hope the rest comes. So yeah, 100%.
Thank you. Peter, anything triggered there?
I love it. Complex stuff as always. I default to Matt in this area, that's for sure.
So here's Daniela Vaz's diagram on using the Mobius strip to show the relationship of the organism, the person, to the environment. And she's really tried to de-emphasize the pathology medical model and promote a functional model. And for her, function isn't impairments. It's not failure of the transverse abdominis to activate. It's more about the function in valued life activities. So in neuro cases, it would be prehensile tasks, things like that, locomotion. Obviously, at the performance end of the spectrum, it could be kicking or throwing or something else. And for our average person, it could be, bending, lifting, and twisting. But the goal would be the goal. And I know we've spoken a lot in this series of webinars about constraints-based motor learning, which is from dynamic systems theory. It's promoted by people like Newell. It deals with a lot of the concepts of ecological validity, which Vaz addresses. And this is where I've learned how much I had wrong about thinking that we should find the faulty movement pattern and then give a corrective. And then I took a step back and I realized that's not even what Professor Yonda, my mentor, taught. He was more like Feldenkrais, where he said it's incorrect to correct. And so really, Rehab of the Spine, 3rd edition, was really my mea culpa about understanding the social and not just dichotomizing bio versus psycho, but also addressing skill acquisition and coaching versus just training or the rehab focused on correcting movement faults. Something seems to happen through gamification when we set up the environment that constrains the person to learn how to solve a movement riddle, such as squatting. If a person is a stupor and they're hunching and bending at the waist, We do now what Pavel Satselin taught from Strong First, which is we let the wall be their coach. We place them facing a wall. We put the object they're going to lift against the wall. Now they have no choice but to move their hips away from the wall to create room. And they have no choice but to upright their spine to create verticalization. And yet we never spoke to them at all. So I want to go forward just a bit and show a picture of this form of communication. Here's an example. This is a video. So we're getting the core for free here. Locking the leg and the arm. That looked easier than before. You feel you're getting the hang of it?
Used to it, yeah.
When Nick Winkleman comes, he'll talk about the value of
Really press.
Using gamification, getting away from internal cues to get the result that we want. If we want to create tension in the system,
Feel your abdominals.
And close the kinetic chain, and you can see we're using a water bottle. I mean, this is COVID-19 period exercise. Very, very basic. I'm going to skip through some of this, and I want to show another example here. We can get in a lunge. So lift the back knee 1 inch, and now you row. That's perfect form. And that's a good weight. We can always pull more than we can push. Good, that's plenty. Switch, because you're going to feel the legs a lot. 5 or 6 is plenty with that. I think Gary will recognize this patient. It's called an isometric lunge. Gary's going to love this. From Reload, Ryan's colleague. The less you lift the knee, the better. Drop it down a little bit. So we don't really tell her what to do. We just one more. Have her kneel and then just bring the knee up off the ground. And now with just minimal coaching, you get one of the hardest exercises that targets the front leg musculature that you could possibly imagine. And that's sort of one of our tricks is to try to gamify the environment and find the hardest thing that a person does well. I'm going to go forward just a little farther here. And I want us to hear from Nate again.
Been dealing with this issue for 9 months, and I've seen so many people, and you get so many different pieces of advice, and you get better, and then you get worse, and then you get optimistic, and then you get pessimistic, and it's really easy to become a complete mental mess. And then you're like, you don't know who to believe, you don't know what the expectations are, you don't know if you're ever going to be healthy again. So sometimes it's just helpful for me to like have these little chats with you, because I go off on my own and, you know, brain goes crazy, and it's helpful for you to help me like refocus and recognize all the progress we've made. So thanks for listening to me. And you're probably, you know, 80%, 90% my coach and 10% my therapist. So,
well, it's funny, but so these are the types of interactions that are now potentiated as a result of guiding by the side, and it's really it's a Hippocratic way of thinking. I'd rather know the person who has the disease than the disease that the person has. We're not ignoring the bio. Matt and Peter talked about red flags. Peter in particular talked about red flags. To my way of thinking, when Professor McGill says, you know, we should all be able to handle the simple cases, and the red flags should just jump right out at us. If you're a coach or a trainer, you know, if there's recurrent pain or severe pain, you're going to refer, stay in your lane. And those of us that are physical therapists and chiropractors, we know when blood work and scans are necessary based on signs of tumor, infection, fracture, etc. But for the most part, what we're dealing with is, as Vaz said, as both Peter and Matt talk about, getting to know the person through motivational interviewing, through reflective listening, which I think is part of your inactive approach, Matt, and being there for the person, supporting them like was spoken about today. Sometimes we just have to listen. I allow a person about 45 minutes in the history before I examine them. And I'll show examples of that with this woman on Thursday when Lorimer Mosley is my guest. This acceptance of each fluctuating aspect of this other person makes it for him a relationship of warmth and safety. And the safety of being led and prized as a person seems a highly important element in a helping relationship. So I love, Matt, you're quoting Rogers here from 1961. This is something that I don't think we can learn too much about. Here's a new book about listening. I noticed that people I interviewed seemed surprised, almost taken aback that I was actually paying attention to what they said. These very successful, well-connected people, not lacking for company, but apparently lacking for listeners. They would always thank me for listening and also often apologize for unloading. People tell us how vulnerable they feel. We have here this ancient Greek quote, "Nature hath given men one tongue but two ears, that we may hear from others twice as much as we speak." So some of this I'm going to pass through as we come towards the end here. But there's one or two things I just want to finish with. I think this speaks volumes. The best thing a patient could say to me is thank you for listening. Maybe if that's our goal, maybe that changes our frame of reference. Is I don't want somebody to say, "Oh my God, you have the best hands," or "Oh my God, you fixed me," or "Oh my God, that was amazing." How about we have the object in mind in the beginning of to let them talk, not to interrupt them. And to see if in fact that isn't something that would make them a more receptive patient. So the last picture that I'm going to show, this one came across my Twitter feed. When I switched from coaching humans to coaching horses, I mourned the loss of explicit instruction and explanation. But today, I believe it was a gift, forcing me to stop relying on telling. But I also had to resist replacing words with physical manipulation. And so here you see, look at her body language, look at what she's doing, look at how the horse is responding, the nonverbal communication. She's not positioning the pelvis. She's not tapping a high shoulder to bring it down. She's not saying, draw your navel in or brace. None of that is even in the realm of possibilities here. What do you think about when you see this, Matt?
I think it's, I think what has been great about this webinar is that it's kind of gone full circle. So we've talked about knowledge translation. We've talked about the biomedical and biopsychosocial model. We've talked about motor control, and all of it comes back to recognizing the agency in others, communication, and guiding, and not telling. And I think all of those areas that we've just discussed comes back to the same theme. So yeah, good job.
Thank you. Thank you. Peter, you want to take us out?
I think Matt just did a wonderful job. You hit on all the pieces. So I have nothing else to add to that.
You guys have been absolutely brilliant. Ryan, any final thoughts?
Oh man, so many. It was I think I don't even know where to start, but I think just relating this all back to, I think what people always want is something actionable things. And I think one of the notes I took down is just the idea of listening. And I think I heard this with Catherine Harmon with Peter and their Barbell Medicine podcast too, is just trying to listen more than talking, you know. I just want to like keep that at the forefront of my head next time I work with any clients or patients, because I think what that's really getting to is not trying to be the hero, not trying to fix anything, and it's just letting them share and then being there with them. So thank you for helping me realize that, and so many other things.
Well, thanks all of you. Thanks to all our listeners from South Africa, Lithuania, Spain, India, too many countries to even mention. Please send in questions to Aaron and Geronimo. Email me questions. We'll pick them up next time with Professor Mosley. We'll be at 4 o'clock Pacific Standard Time in Los Angeles on Thursday with Professor Mosley. Next Sunday, the New York Yankees coach, first female strength coach in Major League Baseball, Rachel Balkovec, talking about Carol Dweck's work on mindset and failure tolerance. And then the week after with the amazing coach and motor learning expert, Nick Winkleman. And then back with Matt the week after that. Those are on Sundays. So I'm pretty excited. Less pressure on me, although I still felt a lot of pressure giving you guys slides of your own work. But thank you, everybody. And remember to reach out to somebody who's elderly or is socially isolated right now. You can still give people a high five virtually, and have a wonderful, wonderful week. Thank you, everybody. Thank you very, very much.
Thank you.